Hello, everyone. Thanks for joining. We will begin in just a few moments. Hello, thanks for joining. Just want to give everyone a chance to jump on. Thanks for joining. All right, let's go ahead and begin. Justine, go ahead and advance just one slide there. Hello, everyone. Thank you for joining us for tonight's webinar, Gene Therapy for Cardiomyopathy, Practical Considerations for Patients. My name is Nikki Butler, and I am the Director of Digital and Social Media for the Dilated Cardiomyopathy Foundation and the Genetic Cardiomyopathy Awareness Consortium. We're so glad you can be with us. We've had tremendous interest in tonight's webinar. We have over 500 people registered at last count, and our team is very excited to share this innovative information with you tonight. Next slide. Just a few housekeeping items. All attendee microphones are on mute upon joining so that you can hear the presenters. Please enter your questions into the Q&A feature of Zoom at any time. We will hold a dedicated Q&A session at the end of the presentation. Next slide. So this is our first poll. So if you could push that poll forward, thank you. We would love to know who's attending tonight's webinar. Are you best described as a cardiomyopathy patient, a family member or friend, a medical professional, or an industry professional? It's always interesting to see these results. These are still coming in. All right, excellent. Let's share those poll results. We have 56% cardiomyopathy patients, 18% are a family member or friend, also 18% medical professionals, and 9% industry professionals. Thank you. I do want you to know that this webinar is being recorded and will be posted on our YouTube channel following tonight's discussion. As registrants, you will receive an email with a link to the recording. Our YouTube channel also houses a library of our previous webinar recordings, and using the auto translate feature, these videos are available in 54 different languages. Next slide. I'll give you a little background. The DCM Foundation focused on dilated cardiomyopathy and created the Genetic Cardiomyopathy Awareness Consortium, or GCAC, in 2023. The effort of GCAC began in 2022 when the DCM Foundation recognized a major gap. Genetics in cardiomyopathy wasn't being widely discussed, not by medical professionals and certainly not by patients. And we realized something important. You can't talk about genetic cardiomyopathy in silos. Many gene mutations cross diagnostic boundaries. For example, a single gene variant might cause dilated cardiomyopathy in one person and arrhythmogenic cardiomyopathy in another. Because of that overlap, we needed a broader, more inclusive approach. So GCAC was formed to raise awareness and provide education about genetics and cardiomyopathy across all types. Next slide. In just the past 2 years, we've made meaningful progress. Awareness of genetics and cardiomyopathy has increased significantly, both in the medical community and among patients. When we launched GCAC, we started with 8 patient groups, and today we've grown to 11, and we're continuing to expand. This momentum shows there is a real need and real interest in understanding the genetic side of cardiomyopathy. Next slide. The 11 patient groups that are participating in the Genetic Cardiomyopathy Awareness Consortium, along with the DCM Foundation, are the Children's Cardiomyopathy Foundation, Lamine Cardiac, the Danon Foundation, Mended Hearts, PLN, SADS Foundation, Women Heart, Let's Talk PPCM, Team Titan, Heart Charged, and the Sudden Cardiac Arrest Foundation. We want to thank each group for participating, for promoting this webinar, and everything that we're doing. It's great to have a coalition of 11 different groups working together to solve a real problem with patients. Next slide, please. It is my pleasure to introduce tonight's expert on the topic of gene therapy, Dr. Quan Bui, a board-certified cardiologist specializing in advanced heart failure, mechanical circulatory support, and heart transplantation at the University of California, San Diego. Dr. Bui has a particular interest and expertise in managing patients with genetic cardiomyopathies, including hypertrophic cardiomyopathy and cardiac amyloidosis. In addition to his clinical work, he serves as an assistant professor in the Department of Medicine at the UC San Diego School of Medicine. His research focuses on cardiovascular genetics with an emphasis on inherited forms of cardiomyopathy. His work has been published in leading medical journals. Dr. Bui is also an investigator in clinical trials related to heart failure and genetic cardiomyopathies. He's a member of several distinguished professional organizations, including the American Heart Association, the American College of Cardiology, the Heart Failure Society of America, and the International Society for Heart and Lung Transplantation. Welcome, Dr. Quan Bui. Now I'll turn the presentation over to you.
Great. Well, thank you for that warm introduction. It's really an honor to be here with GCAC. And, my goal of this presentation really is to kind of mimic the conversations I have with patients when discussing gene therapy clinical trials. And so I spend, hours talking to patients to make sure that they understand the risks and benefits of gene therapy. And I just want to make sure, can everyone see my slides here okay?
Yes, looks good.
Perfect. Okay. So I'm going to start off with some disclosures. So it's important to note that I have a couple of research grants around genetic testing and genetic cardiomyopathies. I also do some consulting for some gene therapy companies as well. Thank you to everyone that has filled out the gene therapy survey. Here are some preliminary results. And the goal was really to understand what are the educational topics around gene therapy for cardiomyopathy and what patients want to learn so that we can kind of focus in on what topics to discuss. And I'm hopefully going to put together some of this information that we can disseminate across the country as well, so other providers can be aware. So, I asked which educational topics around gene therapy would be helpful, and I asked them patients to select the top 3. And it is clear that patients want to learn about the risks and benefits of gene therapy. They want to learn about the clinical trials available for gene therapy, around gene therapy. What is gene therapy and how it works? And so hopefully, from this presentation, patients and family members will be able to achieve that. So here's a brief outline. Again, going to go over the overview of genetic cardiomyopathies. I want to also touch base on the current landscape of therapeutics, comparing cancer versus heart failure. Next, go into gene therapy from how it works, the delivery vehicles, the side effects and immunosuppression, and practical considerations. And then finally end with the importance of genetic testing. And I'm looking forward to the Q&A that's going to happen at the end as well. So cardiomyopathy typically is classified by the heart structure or the morphology. And this is how the heart looks basically on imaging. You may have heard that there's dilated cardiomyopathy where the heart is enlarged. There's hypertrophic cardiomyopathy where the heart is thickened. There's arrhythmogenic cardiomyopathy that can have a certain appearance on cardiac MRI or advanced imaging or pathology. There's restrictive cardiomyopathy and non-compaction. And in a subset of these cardiomyopathies, a genetic cause may be responsible for the disease. And so on the panel to the right here, you can see there's many different genes that are implicated in various types of cardiomyopathies, and there's a lot of overlap too as well. And we continue to learn more about these genetic etiologies that are really exciting in terms of the diagnosis, prognosis, and management of these heart conditions. And while this list is not exhaustive, I think it tells you and shows you how expansive we know about genetics and cardiomyopathy and how much more we will learn in the future. I think one disease I wanted to highlight, and something that's near and dear to my heart, during my training, I was exposed to Danon disease, and my mentor, Dr. Eric Adler at UCSD, is an expert in the management of this heart condition. And this really got me into genetic cardiomyopathies. And so Danon disease is an X-linked genetic disease that leads to a systemic disorder. And it's due to a mutation in a gene called LAMP2, and it leads to decreased production of that protein. And when you have decreased production of that protein, it can lead to all these different types of side effects or symptoms. And so it can affect the neurocognition, the vision, the gastrointestinal system, the skeletal muscle. But most importantly to a cardiologist is it can affect the heart. And we have seen some of the thickest and heaviest hearts ever coming from these patients. And since it's an X-linked disease, mostly it affects males, but can also affect females as well. And as you can see here on the right, it's kind of the natural history of Danon disease in males and females. And so in males on the top there, you can see that patients develop end-stage heart failure in their teens to early 20s requiring heart transplant. The standard of care in this patient population, at least for males, is heart transplant. And while it treats the underlying cardiac disease and the end-stage heart failure, it really doesn't affect the extra cardiac disease. And so what I wanted to highlight from this example is that most genetic heart diseases, including Danon, lack effective treatments that really target the underlying basis of disease and can treat the underlying disease as a whole. So let's talk a little bit about therapeutics in the year 2025 and comparing cancer and heart failure. So in cancer, it's interesting. You treat as soon as the disease is detected, even in the absence of symptoms, right? You see a mass or a tumor on imaging, and we're already, seeing the oncologist and talking about therapies. And therapies are really based on the genetics and the endotype, okay? You take a sample of the tissue, the tumor tissue, you can do genetics on it and kind of understand the different mutations and then target the treatments according to that. In heart failure, on the other hand, therapies are generally started once patients develop symptoms, right? And the therapies are really based on the heart structure, right? Where I talked about the different types of cardiomyopathy and the phenotype. And for genetic cardiomyopathies, I think that's the case. We are repurposing some of these heart failure medications to mitigate symptoms or treating symptoms. And the guideline-directed medical therapy, while they have really changed the game for heart failure, including beta blockers and Entresto and SGLT2 inhibitors or mineralocorticoid receptor antagonists, they're mostly there to mitigate symptoms. And so, we really need a push towards disease-targeted therapies that really address the underlying genetic or molecular mechanisms of disease. And I think this is really going to be important so that we can offer personalized and effective treatments, just as we are doing in cancer. And I would say that heart failure is trying to move towards the paradigm in oncology or cancer, but we're still behind, but we're obviously moving towards that goal. And so our understanding of cardiovascular genetics has dramatically improved over the last few years and has really become important in the clinical management of cardiomyopathies. I really want to highlight a couple of things that's been important in diagnosis and prognosis. Really determining the genetic etiology of cardiomyopathy has improved both the diagnosis and prognosis. In hypertrophic cardiomyopathy, we know that certain genetic variants, especially at the sarcomere, have been associated with higher risk of adverse outcomes, including arrhythmias and heart failure compared to patients without the sarcomeric variant. We know that it affects management in certain cases where we know that certain mutations or variants that cause cardiomyopathy, like lamin A, DSP, vitamin C, phospholambin, and RBM20, carry a high risk of abnormal heart rhythms, malignant ventricular arrhythmias. And so these patients have a high risk of sudden cardiac death, and we have different guidelines to support the implantation of defibrillators in this patient population. And then really, genetic insights have allowed for tailored therapy and really mechanistic-based strategies. So we have new therapies treating the cardiac myosin, targeting the cardiac myosin, the hypertrophic cardiomyopathy. We have different therapies targeting cardiac amyloidosis. And then finally, what I wanted to kind of focus in on this presentation are these nucleic acid therapies or gene therapy, which are new therapies being developed to treat rare and genetic diseases. And essentially, the goal is to deliver some genetic material, DNA or RNA, to treat these diseases and really provide the cells of the heart the instruction manual to basically lead to increased protein and hopefully treat the underlying genetic form of disease. And I'll go into more detail in the coming slides. So gene therapy, how does it work? I think it's important to kind of go back to the basics, and I'm not going to go into a lot of detail about genetics, and that's not the goal of this presentation. But I think it's important to understand that every person has 2 copies of each gene, right? And in a healthy person, both copies of the gene work together to produce the right amount of protein that the body needs. Okay, and so if you look at this figure here on the right, the top is normal. You have these 2 genes at the top, and they are able to be, translated into the appropriate amount of protein. Okay, in certain diseases that affect the cardiomyopathy or the heart, there's usually 2 different problems that happens. So one, where there's not enough protein, and that's called haploinsufficiency. And the other one is it leads to harmful protein, which is a dominant negative mechanism. So let me focus on the not enough protein or the haploinsufficiency part. Again, to direct you to this figure here, again, you have a normal functioning gene at the top, and then you have a mutation in the gene at the bottom. And while the top gene, normal one, produces enough protein, the one that's mutated produces half the number of protein. And so this leads to different types of cardiac diseases. And so gene therapy, what it does, there's 2 different strategies in this type of situation. One is to deliver the genetic material, a normal functioning gene, to see if we can improve the amount of protein, normal protein that is produced. Okay, that's strategy 1. In strategy 2, you can actually do genetic editing, editing out that mutation in that abnormal gene and seeing if you can increase the number of, increase the functional protein that's developed or produced. In the second problem, the harmful protein or dominant negative, what happens there is you have a mutation in the gene that leads to maybe a normal protein, but it's abnormal in function, okay? It causes something abnormal to happen that leads to disease. And so you can either deliver genetic material to the heart cells to silence that harmful protein so that it's not made, or you can also do that genetic editing approach to correct the mutation and decrease the amounts of harmful protein. So delivery. Delivery to the heart, getting these gene therapies to the heart is a really big problem, okay? I think this quote by Inder Verma, who's been a gene therapy pioneer, kind of highlights this. There are only 3 problems in gene therapies: delivery, delivery, and delivery. So as I mentioned, delivery of the gene therapy to the heart is really hard, and sometimes we have to use high doses of a delivery vehicle, which I'll discuss in the future slides, that can lead to harmful immune-related side effects. And so it's really a careful balancing act to get enough of the genetic material to the cells, but also not to cause immune-related side effects that causes problems for patients. And so the delivery of the medicine, as I mentioned, we can't just put these genetic medicines into the body and have them be directed to the right place, right? And they need a delivery vehicle. And there are 2 different types of classes of delivery vehicles. One is a viral one, which includes mostly adeno-associated viruses. Those are the most common, or AAV, and they can target different organs and tissues. And I'll discuss that into more detail in the future slides. And there's non-viral vehicles like lipid nanoparticles, which are the most common. And I'll talk about the pros and cons of that approach in future slides. And then finally, there's also bioconjugation and using different types of modifications or antibodies to direct the gene therapy to the appropriate place. And as I mentioned, delivery of gene therapy to the heart is challenging, and viral vectors like the AAVs, adeno-associated viruses, are the best currently. And this figure here on the right just shows, you have to get the delivery vehicle to deliver the genetic material to the right area, and then really get it into the cell so that it can be used appropriately to make more protein or to silence certain proteins. So adeno-associated viruses, these are the viral vectors. And what they're basically composed of are non-pathogenic protein shells called a capsid. And they're the things that carry the small piece of genetic material inside and protect it so that it's not going to be broken down by the various different systems in our body. And it's important to note that the AAV is genetically modified, so the virus's own genes are removed and they're inactive. They're not going to cause an infection, okay? I think this is like a really clever approach because it takes advantage of the biology and the fact that viruses are adept at infecting and getting into human cells for, however long it's been, right? So really, it's Mother Nature and biology finding ways to get them into cells that we're taking advantage of. And some of the advantages are that it's safe and well studied. And we have a strong record of safety of AAVs in clinical trials, and there's approved gene therapies that use this mechanism of delivery. You can get specific tissue targeting. There's different types of AAVs that can go into various tissues, and the one that has been most used for the heart has been AAV9, although there's been a lot of technological advancements in the AAV space, and things are constantly changing, but historically AAV9 has been the best. And then you can really get long-lasting effects and sustain gene expression with this type of delivery. Some of the challenges with AAVs is that you can have they can only package in some small amount of genetic material, so that limits some of the genes that we can deliver to the cells. There's also pre-existing antibodies. Some people may have been exposed to certain viruses or AAVs in the past, and that can reduce the effectiveness and prevent future dosing of the gene therapy. And then, as I mentioned, there can be immune-related side effects triggered by the response to AAVs. Not the AAV is causing an infection, but the body is responding to a foreign thing in the body. Next class I want to talk about in terms of delivery vehicles is non-viral. So these are going to be your lipid nanoparticles. Those are the most common ones that we have at this time. And what they're made of are lipids, they're fats that can be assembled into a small sphere. And you can put the genetic material inside this small sphere and they can be delivered into the cells. And some of the advantages that are associated with lipid nanoparticles are they're milder immune-related side effects. There's still some, but compared to AAVs, they're more mild, okay? I think that it can also be scaled relatively quickly and mass-produced. I think that's quite a benefit. And then repeat dosing is possible. It's not affected by neutralizing antibodies or exposures to previous viral vectors. Some of the challenges, and this is one of the biggest challenges with lipid nanoparticles, is that it doesn't do a good job of getting to the heart cells. It does a great job of getting to the liver, but not to the heart cells, and that's a problem. And also there's more of the short-lived expression, more temporary effects rather than long-term, and usually they need to be have redosing. The last delivery vehicle I wanted to mention is bioconjugation antibodies. So some people have engineered some antibodies designed to bind to certain cells and allow for more targeted delivery of the genetic material. And so the transplant receptor 1 is on cardiac cells and skeletal muscle. And so using this kind of antibody approach or different chemical modifications can help direct the therapy to the right place, and this limits off-target effects. So far, it seems like there's milder immune-related side effects compared to AAVs and lipid nanoparticles, and repeat dosing is possible, similar to lipid nanoparticles, where it's not limited by the presence of neutralizing antibodies. Some of the challenges with this approach that we've seen, but hopefully will be improved upon in the future, is that right now it's limited to RNA therapeutics, which are mostly effective in gene silencing. I don't think I've come across a scenario or a case where they've been able to deliver DNA to the nucleus. But again, this field is changing so rapidly. And hopefully that could be something that could be addressed in the future. And then there's short-lived expression, more temporary effects rather than long-term. And this is kind of a figure here on the right showing the antibody, that blue and green type of structure, and attached to that is some of the genetic material that cleverly gets delivered to the target cell and then internalized into the cell so it can do its appropriate job. Another thing about delivery is talking about systemic versus local administration of the gene therapy. I will say that most of the gene therapies at this time are given through an IV in the arm, so an infusion that's systemically delivered to the rest of the body. But there also is local administration of the gene therapy, either by intracoronary, so injecting the gene therapy directly into the coronary arteries, and also directly, infusing it into the heart muscle itself. And the reason why this is attractive is because, or why other people have pursued this, is because it can reduce the dose required for delivery of the gene therapy to the heart cells by close to 50 to 70 times. And this is important because we know that higher doses of the gene therapy require more high doses of the delivery vehicle, like the AAV, and the lipid nanoparticles, which in turn can lead to immune-related side effects. So if we can do it intracoronary or intramyocardial into the heart muscle, you can decrease the risk of immune-related side effects. And then later on, I'm going to talk about immunosuppression. You can also avoid immunosuppression, including steroids. Some of the cons, it's a little bit unclear, the actual uptake of gene therapy into the cardiac cells, and it requires an invasive procedure. So side effects and immunosuppression. So as I mentioned before, the body can recognize the delivery vehicles as foreign and react to those delivery vehicles and lead to immune-related side effects. I would say that this is mostly pertinent to AAVs, the viral vectors, but can also be seen in non-viral vectors too as well, including the lipid nanoparticles. As I mentioned, it's usually associated with higher doses of the gene therapy. So some of the side effects that people should be aware about are liver inflammation or hepatotoxicity. This is usually the most common depending on the type of delivery vehicle that is required, and it leads to elevated liver tests. And as I mentioned, it can be usually mild, but can also be severe. You can also see heart inflammation, for example, myocarditis. Again, that's also rare and typically mild. And what we typically see are elevated cardiac enzymes like troponin, or also in some cases, a little bit temporary weakening of the heart. You can also see blood issues, a phenomenon called thrombotic microangiopathy. Also very rare, but can be severe. It can lead to a reduction in blood counts and kidney problems requiring blood transfusions and dialysis. But usually we can identify this early and treat patients with immunosuppression so that there are no long-lasting effects. So that takes me to immunosuppression. Immunosuppression has been used to really calm down the immune system, so it doesn't react to the body, doesn't overreact to the gene therapy, and specifically to the delivery vehicles, right? And depending on the gene therapy and the patient comorbidities and history, we can kind of tailor some of these immunosuppression regimens. I would also like to mention that immunosuppression, while they're helpful in this situation, also carry other side effects, and it can temporarily increase patients at risk for infections. There are usually two different approaches and therapies. I like to classify them as steroids, like prednisone, and then as well as advanced immunosuppression. And depending on the gene therapy and the different protocols, you can have a preventative approach where steroids are given before and after the gene therapy infusion with the hope to just reduce the amount of immune-related side effects. Or you can have more of a reactive approach where none of the immunosuppression is given beforehand, and we kind of wait to see the side effects appear before giving treatment. And again, that's kind of balancing the risk that immunosuppression can lead to infections temporarily. And also within this reactive and preventative approach, there's advanced immunosuppression, including mTOR inhibitors like sirolimus, calcineurin inhibitors like tacrolimus, antibodies, treatments towards anti-CD20 antibodies like rituximab, and then complement inhibitors like eculizumab. So again, these are all therapies trying to mitigate or reduce the side effects related to gene therapy. So practical considerations. These are things that I put together, and they're not meant to be exhaustive, but these are some of the things that I discuss with my patients when talking to them about a clinical trial involving gene therapy. And I think it's really important to discuss these things with your provider or the principal investigator of the clinical trial before proceeding. So the first one I wanted to bring up is an unmet clinical need. How does this gene therapy compare to other available treatments for my condition? And I'm going to go into that in more detail in the following slide, but that's one thing that I absolutely discuss. Number two, delivery. what delivery system is used. Is it a viral vector? Is it a non-viral vector, like lipid nanoparticles? As I discussed before, is it systemic through an IV, or is it local administration through the coronary arteries or intramyocardium inside the heart muscle? What are the side effects and safety? What are the possible side effects? What is the dose of the gene therapy? We know that higher doses of the gene therapy are more associated with immune-related side effects. Is there immunosuppression involved in the gene therapy protocol, like steroids and some of the other advanced immunosuppression medications that I discussed? What is the disease trajectory for patients? Does my disease trajectory have a poor one? What happens if gene therapy does not work? Will I be eligible for another gene therapy clinical trial? And effectiveness and clinical trial stage. How likely will the gene therapy work, right? What's the data been like in the preclinical studies, or if there's been a phase 1 trial, how effective has it been? And has this been tested in other people with a similar heart condition? And so, I think these are the 3 things I always address with patients: disease with unmet clinical need, disease trajectory, and then risk and safety. And some of the other ones I also address too as well, depending on the certain patient. So I'm going to go into these into a little bit more detail. So practical consideration number 1, does my cardiac disease have an unmet clinical need, right? Many patients with devastating diseases and rare diseases have very few treatments available, right? And they may be more willing to accept an unknown chance, an unknown side effect or a side effect with a gene therapy, right? But it's also important to know that there are approved disease-targeted treatments for certain diseases, right? We have hypertrophic cardiomyopathy, as I mentioned. There are some disease-targeted treatments like cardiac myosin inhibitors. In cardiac amyloidosis, specifically TTR, we have stabilizers and silencers. And so, I make sure that if there are some targeted treatments, that patients are on those treatments or consider those treatments before thinking about participating in a gene therapy clinical trial or gene therapy at all. An example of a disease that doesn't have disease-targeted treatments, I would argue, is arrhythmogenic cardiomyopathy, right? And in this case, we have repurposed heart failure medications that really treat the symptoms. And ultimately, lots of these patients will require heart transplantation down the road. And so this patient with arrhythmogenic cardiomyopathy may be more willing, and I'd be more willing as a provider to recommend a gene therapy or a gene therapy clinical trial. Again, this is just kind of my approach to gene therapy recommendations and considerations for patients, and everyone's a little bit different. But again, it's a nice framework for people to understand when thinking about whether this might be a good thing for them. Practical consideration number 2, risks and safety of gene therapy. How safe is gene therapy, and what are the most common side effects? Fortunately, there have been a lot of clinical trials and studies around gene therapy, and they've been largely safe. But I have to say that there have been a few deaths that have come along the way. And, we always remember the death of Jesse Gelsinger. This happened close to 25 years ago. And he was a patient with a rare metabolic disorder. And he enrolled into a clinical trial for gene therapy, and unfortunately passed away from immune-related side effects. And we've learned a lot from Jesse Gelsinger's case, and we've really worked hard as a field to make sure that our patients are safe. And we've helped a lot of people along the way from gene therapy. And I just wanted to highlight that gene therapy does come with risks, right? But I compared to therapies for chemotherapy for oncology and cancer, right? And transplant for end stage heart failure. Like those also carry significant risks, and so it's really important for patients when they're considering these things to consider the side effects and risks, and informed consent is critical. So these are important things to discuss with your provider. The last practical consideration I wanted to bring up is disease trajectory. How severe is my disease trajectory? If I get gene therapy now, can I qualify for future gene therapy trials or treatments? And every disease is different, right? I present to you here on the right-hand side, two different figures. The top one being the functional decline in patients with Duchenne muscular dystrophy, which is a genetic condition that can lead to progressive muscle weakness and cardiac and pulmonary complications. And we know that by age 5, that lots of these patients have progressive muscle weakness, and then by the age of, in the late teens, early 20s, they have severe cardiac and pulmonary complications. And so gene therapy in this patient population with a pretty severe disease trajectory makes sense, and early on, before there's too many symptoms, makes a lot of sense. In the bottom panel, more relevant to cardiomyopathy is arrhythmogenic cardiomyopathy. And so we know that as time goes on, usually in the 20 to 40 range, we might start to see abnormal heart rhythms, ventricular arrhythmias, and then later on they develop heart failure and requiring a heart transplant potentially. And every arrhythmogenic cardiomyopathy, as I mentioned, is a very it's a lot of different genetic etiologies, and some that are non-genetic, and the different disease trajectories can be dramatically different. But if there's a certain genetic mutation that we know that leads to very significant and poor disease trajectory, it may make sense to do gene therapy earlier on. And so these are the types of things that I'm thinking about when discussing with patients. And again, talking with your provider is so important. And one other thing that kind of comes up too is, after one gene therapy, the body can build up immunity to these different delivery systems, specifically the adeno-associated viruses or AAV viral vectors, and that can make you ineligible for future gene therapies. So importance of genetic testing, but first, before I go to that, I want to talk about one success story, and that's gene therapy for Danon disease. So going back to where I started and how Danon disease became something that I was near and dear to my heart, working with Dr. Eric Adler and also Dr. Barry Greenberg, who's shown here on the slide, is that there's been a successful gene therapy, at least phase 1, involving an AAV9 for Danon disease, right? And as I mentioned, Danon disease usually affects males most significantly and leads to end-stage heart failure requiring transplant in their late teens to early 20s. And what they found in this phase 1 study was that overall the gene therapy was safe, and most of the patients, all the patients recovered from any sort of immune-related side effects, which was great. But what also they saw was that they saw increased expression of that LAMP2. Remember, the mutation in LAMP2 causes Danon disease. They saw increased expression of LAMP2 inside the heart muscle. So when they did biopsies of these the heart muscle, they saw increased expression of that gene and protein. And this is really exciting news because, again, the goal of gene therapy is to deliver the genetic material to the heart and increase the amount of available protein, in this case, LAMP2. And they saw also on different cardiac blood tests and imaging tests that the heart function looked like it stabilized / improved. And so this quote from Dr. Greenberg saying that these boys with Danon disease, contrary to what was seen in the natural history studies, are alive and doing well. And so with these gene therapies, and success, there's been a lot of gene therapies being developed or that are in the pipeline for cardiovascular disease. So this article was from 2021. There were 80 gene therapies for cardiovascular disease at that time, but there are probably over 100 in the development stage to phase 3 to later phase 3 development, at least in the cardiovascular disease as a whole. And I put together a representative list of maybe some of the gene therapies for cardiomyopathy. And again, this is not an exhaustive list, and there's a lot of gene therapies being developed, so I cannot fit all of them onto a single slide. But I wanted to point out some of the most common ones, the most relevant ones that I've seen or come across. And those include for hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, dilated cardiomyopathy, non-ischemic cardiomyopathy, transthyretin cardiomyopathy, and Danon disease. And I've listed the genes here that are that the gene therapy is trying to tackle, the different delivery vehicles from AAV to lipid nanoparticles to antibody conjugation. I highlight also the delivery route, systemic IV infusion versus intracoronary injection, whether there's immunosuppression involved in these clinical trials, what is the study phase from preclinical to phase 3, and then really the presence of disease-targeted therapies, whether there's FDA-approved disease-targeted therapies for that certain disease, for cardiac myosin inhibitors and hypertrophic, and also TTR stabilizer and silencers for transthyretin. But I think there's a big call to action. Really, the ability to treat starts with the ability to identify, right? And so what we've noticed is that there's not enough patients getting genetic testing. So if you look at this funnel graph on the right, where the big funnel is all patients with cardiomyopathy, we've known that there's dramatically underutilization of genetic testing. If only 10% of those patients are getting genetically tested, that only a subset of those patients can get precision therapies or gene therapy, and eventually improved, hopefully, patient outcomes. And so we really need to do a better job to improve the uptake of genetic testing. And I know that there's been separate webinars on this topic. And so hopefully this is a call to action for providers, patients, and industry partners who are also on this webinar. So in conclusion, gene therapy is really moving us towards an exciting time, really personalized treatment for cardiomyopathy that treats the underlying root cause. I think, as I mentioned, delivery remains one of the greatest challenges, and we have to find safe and effective ways of delivering the genetic material to the heart. Right now, AAV vectors are the most efficient cardiac delivery, but as I mentioned, they have immune-related side effects and often require immunosuppression medications. I think there are some emerging delivery technologies like lipid nanoparticles and bioconjugation, antibody-guided delivery that may offer safer and more targeted options in the future. And then when considering gene therapy, patients and providers, there must be informed consents, and thinking about the unmet clinical need, the safety profile, and the disease trajectory are critical. And like I said, choosing gene therapy is a big decision. You need to talk to your provider or talk to the principal investigator of the clinical trial and fully understand the risks, benefits, and alternatives. And then finally, genetic testing is a gateway to personalized treatment. And I hope that we can improve the uptake of genetic testing so that we can treat more patients and improve outcomes in the future. And that's it. These are my references. And again, another plug to fill out the gene therapy survey. I appreciate everyone's who has already filled out the survey at this time. It's been really helpful to understand what are the the barriers to gene therapy, what type of educational forums are best to educate patients. And so I appreciate everyone's and thank everyone for their help in advance. Thank you so much, and I'm happy to take any questions.
Thanks so much. I'm Greg Ruff, sitting in the background. Quan, that was great. This was a deep dive into it. We wanted to do a deep dive. We get a lot of questions from patients. We had over 500 registrants for this webinar, and we know that gene therapies are coming. There's a lot of questions, and we wanted to give you what we think is a very fair, and I think we delivered it. Quan delivered it, an unbiased presentation on gene therapy. So thank you. That was great. Everyone, thanks for attending. We've got some questions. Again, I'll be reading the questions to Quan. If you have questions, please in the Q&A, put them in there, and we would be happy to answer them. If we may go a few minutes over, for those of you that want to stay, that's great. But please feel free to put in the Q&A any question you have. First question we received tonight, Quan, was why is TTN such tighten a high percentage on the chart? Is it the one that we know the most about?
Yeah, it's a great question. So I would say Titin is the most common cause that we know of a genetic dilated cardiomyopathy, right? And so with it being the most common, we probably have the most information about it, and it's been most studied. And there are some gene therapies being developed for TTN or Titin. And so hopefully in the coming months to years, we'll have an available treatment. But I think to answer the question, it's mostly because it's the most common and it's the largest gene in the, and so that's why we know most about it at this time.
Perfect, thank you. And we're still on the Titin thread. Can anabolic steroid use activate or trigger a Titin variant to heart failure? So triggering them to heart failure.
Great question. So, really believe in this two-hit hypothesis for genetic cardiomyopathy. So we think that, there's obviously not everyone with a Titin mutation will develop a dilated cardiomyopathy, but there's a thought that if you have an underlying predisposition, right, you have some sort of genetic variant like Titin, and then you drink alcohol, you have a second hit, or you have pregnancy, or you get chemotherapy, that you can be more likely to develop a dilated cardiomyopathy. There hasn't been any sort of, I think, studies looking at anabolic steroids specifically, but I really counsel my patients with a genetic cardiomyopathy who may have an early phenotype or are asymptomatic that they should avoid any sort of triggers that potentially could increase their risk. So I do a lot of counseling around alcohol use. I really talk to them about starting medical therapy, treating their underlying hypertension, high blood pressure if they have it, treating their underlying cholesterol, stuff like that. And but yeah, to answer the question, we don't have any clear data around anabolic steroids. But again, I would advise that patient, if that person were to come to my clinic, that to avoid it if possible.
Perfect, thank you. Are these gene therapies being designed to stop the progression of cardiac disease, or will they be able to reverse the effects of a disease that is already present?
That's a wonderful question as well. And so that's something we don't know at this time. The thought process is this. If we can treat the underlying genetic basis or cause of the cardiomyopathy early before there's too many significant symptoms, we think that it's going to be most effective, right? If we try to do gene therapy for a patient who has end-stage heart failure, right, they're needing a transplant in a couple of months, then we think that the heart is probably scarred down or is fibrosed, right? And that the reversal or the improvement is going to be more marginal. And so we kind of want to find this perfect patient where we don't want to do things too early, right? When they don't have any symptoms, and then we subject them to the risk of gene therapy. But we don't want to do it too late. So it's really that Goldilocks patient where they're they're having some symptoms and that we think that we can reverse and hopefully cure their underlying genetic heart disease.
Great, thank you. From Christy, on the graph that showed ACM progression, what does the dotted line that goes up and down indicate, if you can recall? And maybe while you're looking, we can ask another question if you'd like, or do you want to take it?
I'm trying to go back to my slides here. I don't know specifically what that dotted line means. Actually, I'll have to go back and look at the legend. But Christy, I can send you a message or email later on.
Okay, thank you. Thomas is asking, if I have genetic testing confirming the gene defect causing my cardiomyopathy, how can I self-identify as a potential candidate for gene therapy? Great question, Thomas.
Yeah, that's a great question. Yes, so if you have a genetic variant that is an explanation for your cardiomyopathy, then you should talk to your provider, right, about whether there's a clinical trial that's involved. I know obviously GCAC and the different patient support groups can also help facilitate those things if your provider doesn't feel comfortable or doesn't know much about the gene therapy clinical trials. But yeah, you should reach out to all avenues, and gene therapy clinical trials are being done across the country, I would say in more specialized places. But yeah, reach out to your provider and reach out to your patient support groups.
Great. No, thank you. And there's clinicaltrials.gov. It's a little cumbersome. We've got on both our DCM Foundation and GCAC websites some sort of helpful hints to navigate that, but clinicaltrials.gov would have, you could type in cardiomyopathy or dilated cardiomyopathy, and it'll bring up all the therapy or all the clinical trials going on.
And it's also, I think the American Society of Cell and Gene Therapy, they also have, I think there's also a link from GCAC to there as well. And there's like a clinical trial gene therapy finder. So I figure you can probably type in your genetic variant and might be able to direct you. But I think, again, just relying on all the resources that you have, again, this is like a new emerging field, and there's not a lot of information. At least some of the providers don't feel comfortable. So that's why reaching out to all avenues is important.
Makes sense. Feel free to reach out to us, anyone. So from a great partner of ours at Team Titan, Sarah Foy, Dr. Bui, do you want us to promote Share the Survey within our online communities? Do you want us to promote or give it to Team Titan and other groups? Or I know you've got a pretty good response so far. Would you like to get more responses?
Yeah, thank you, Sarah. Glad that you were able to participate in this webinar, and thank you for your willingness to help out. I think for now, we've had a great response from this webinar, and my whole goal was to make sure that we had enough content that people listening would enjoy the content. But if the people who listen, if they could also fill out the survey, that'd be helpful if they haven't done so.
Oh, great. Thank you. From Lauren, are there specialists for children with PKP2? Good
question. It depends on the center, right? I can only speak so much about the adult population because that's the population that I deal with. But there's arrhythmogenic cardiomyopathy centers across the U.S., with the big sites being, Johns Hopkins and UCSF and those types of places. But obviously, arrhythmogenic cardiomyopathy is being a lot more common and more freely diagnosed, and so there are probably experts in the area. But I'm sure Christy and other people from the different support groups can also help direct you to the right person if there's any sort of experts in the area.
No, I think that's great. Lauren, a couple of things. There's the Children's Cardiomyopathy Foundation, CCF, Children's Cardiomyopathy, just Google it. I think they would be a great resource, great organization, been around for quite a while. So the Children's Cardiomyopathy Foundation. We also have a Facebook group, a PKP2 Facebook group, I think with a couple hundred people on. You can join that. Go to our webpage, www.geneticcardiomyopathy.org, and pull down, I think, patient resources, and you can see the gene-specific groups. You can join that group with a couple hundred, I think, people there. I'm sure there's some folks that have children with the disease and with that gene mutation and could help too. So 2 great places. Will there be a phase 2 for HCM for MYBPC? MYBC3. Yes.
Yeah, that's also a good question. I don't know exactly where the field is moving with that clinical trial, right? I think Tanaya is the one doing that gene therapy clinical trial. So I would talk to your provider about that, or look into on the website Tanaya Therapeutics and get more information. But I don't have that, and I don't want to direct you in the wrong way this time.
Okay, great. Again, from Amanda, what's the best way to keep up with available gene therapy trials for particular mutations? Again, I think, I'll answer a bit of this. We already talked about it. We have a lot of gene-specific groups. We do publish a lot of research studies and clinical trials that are going on. Sometimes we feel bad about that because we feel like we're overloading people. But what I'm seeing, at least with the questions here, is that people want to know kind of what's available. Again, the other, I think, is clinicaltrials.gov. It's pretty simple. If you want to email us at info@geneticcardiomyopathy.org, we can also point you in a few different directions too.
Yeah, I think that's a good point, Greg. I think a lot of people are interested in that, so maybe we need to find a better way. I agree. Clinicaltrials.gov is actually very clunky and difficult to navigate. So we should think about that. But I think the American Society of Cell and Gene Therapy has a really nice clinical trial finder.
Okay, now that's great. From Renee, I have tested positive for FLNC. Should I get tested for other genes? If yes, how do I do that?
Yeah, so typically what I'm assuming is that if you got tested, you probably got the panel, right, of cardiomyopathy genes. And so I'm assuming they tested the entire panel, unless you had another family member that had that genetic mutation. They specifically tested you for that. So I'm assuming they probably did test for everything. So it depends on the certain situation, but usually it's a single variant typically that can be implicated in disease, but obviously there's also multiple variants that can lead to other types of phenotypes or different types of clinical signs and symptoms as well.
Great. And Renee, we'll have a slide up at the end here about a free genetic testing service presented by the GCAC patient groups. From Christopher, could you please share the references you cited in this presentation? I can probably answer that. So we actually will send you a link we'll publish on our website in a day or two, the actual presentation. And anybody that has registered for the webinar, we will actually send you a link. So you will have from our website, and then also a link so that you'll actually be able to get the presentation and view it a day or two after this evening's event. That's great. From Cheryl, wondering if age of patient has any bearing on choice to participate in trials. I'm a parent of a young genetic DCM patient in advanced heart failure.
You're saying age is a barrier to participating?
Yeah. Yes. And so and maybe it means if they're not an adult, if they're underage.
Yeah, I think that's a good question. Each clinical trial has a different age group, and obviously certain genetic variants can cause cardiomyopathy in children, right? So it's going to be gene specific, right, depending on the type of genetic cardiomyopathy. But I think that's why it's still important just to reach out to look into the clinical trial, reach out to who's running the clinical trial or a local site and get more information about it. We do get patients who self-refer themselves to these clinical trials that we're running, helping run it at UCSD. And so if you can reach out to the principal investigator or someone in the area, that would be the best way to go to get that information and confirm whether age would be a barrier or not.
Perfect. Thanks. From Maryland, how will lipid nanoparticles be used to help the heart?
Yep. So I talked about lipid nanoparticles being one of the delivery vehicles to get the genetic material to the cells. And I mentioned that right now it's best at delivering it to the liver and not so much the heart, but people are developing different modifications of lipid nanoparticles to see if they can be better delivered to the heart cells specifically. But right now, I mean, lipid nanoparticles are being used in certain gene therapies for hyperlipidemia, for PCSK9, right, inhibition. It's also being used in, it's been used in cardiac amyloidosis. Patisiran is an example, silencer therapy, right? And it's also being used for CRISPR for cardiac amyloidosis too as well. So it is being used again, but some of these processes are in the liver that ultimately affect the heart. So that's why it's effective in those certain situations. But in other genetic cardiomyopathies, it won't be all that effective unless we develop new ways of getting that to the heart cells. Hopefully that makes sense.
Thank you. We've got a few more. If a child has late gadolinium enhancement on a heart MRI, and I didn't pronounce that correct, I apologize, and known PKP2 mutation, does that mean there is damage? The child's cardiologist just said to wait and repeat in a year, but it seems concerning.
Yeah, I don't want to get into, specific patients here, but LGE or late gadolinium enhancement can indicate some scarring of the heart, and it can be seen in arrhythmogenic cardiomyopathy patients. So again, I just wanted to state the facts. It can be related to scarring, and we see that, and typically what we do is kind of monitor over time and trend it over time to make sure that it's not progressing. But yeah, I defer to the cardiologist's recommendation for that question.
Good question. We can't give out medical advice because obviously, we can't do that legally, and Dr. Bui doesn't have the detailed information. Another one, I have Titin gene, familial cardiomyopathy, and reoccurring pericarditis. How do I find if I qualify for gene therapy? Again, I wanted to answer that, but we've sort of, clinicaltrials.gov. I think, obviously, Sarah was here with Team Titan. They have a Facebook group. You should join that organization. You should join the Facebook group at Team Titan. A lot of information is disseminated from there. So, whatever your gene or your disease state is, you should think about joining groups that represent that, because you'll get a lot of information either from the people that run the organization or from the patients themselves. So what is the take on dilated cardiomyopathy with the HCN4 gene variant? I have not heard about that gene mutation.
Yeah, again, there's a lot of different genetic variants that can cause cardiomyopathy, and we're still learning, right? Genetics is, there's 20,000 genes, right, in the human body, and subset of those genes can affect and lead to cardiomyopathy. And we're still in the infancy stages of cardiovascular genetics, to be honest with you. And we're the infancy stages of gene therapy. So I don't have a great, and we don't understand every gene and understand the true natural history of these different genetic variants. That's why it's so important to find groups and participate in different studies, and even natural history studies, that can understand, how these genes affect what the disease trajectory is. That will help us in terms of deciding on when to treat with gene therapy or some other medications. So again, I don't want to give you any specifics, and I don't actually know the specifics of that variant. It's just there's so much that we need to know and figure out. But I would encourage you to participate, and if there's any studies that are being done, to hopefully contribute some of your information that we can learn more.
Very good. We just got a few more. It sounds like taking a cortisone shot to stop an allergic reaction is not good to do if you have cardiomyopathy. No gene has been detected for it. Is this correct? How do you stop reactions if you don't take a cortisone shot?
I'm trying to think about what this question is specifically asking. Is it related to preventing immune-related side effects with gene therapy, or is this a separate thing altogether?
I don't know.
Yeah. I mean, I'll just say, yes, we want to give immunosuppression medications to prevent these immune-related effects, but you're right. There are, with steroids and other immunosuppression medications, can increase the risk for infection. It can lead to increased fluid retention, right? And that can be bad in heart failure. So again, we these therapies are difficult and there's difficult decisions to be made. But again, we're all here to try to understand and make sure that patients get the appropriate therapy and are safe.
Perfect. Thanks. It's great. We're hearing from a genetic counselor. Hi there, from Shay. Hi there. I'm a genetic counselor who's trying to improve the uptake of genetic testing in our medical system for our cardiology patients. Any advice you could give Shay on the best way to promote this among cardiologists who are hesitant to order? Also, for the patients in the call, genetic counselors can take the time to review your genetic test results in detail and discuss what it means for biological family. Yeah, so I'll do the second part, and then you could do the first part. Yeah, genetic counselors are really important with with getting a genetic test without, if you have a positive result, and you really have to talk to a licensed genetic counselor. They can give you all sorts of great information. They can help decipher the very complicated results. Talk to your family. What do I do? What does my family do? So again, a plug. I've been on the American Board of Genetic Counseling for almost 5 years. Really, really important. For any genetic test that you talk to a geneticist or more likely a genetic counselor. How do you, what do you do? Do you wrestle with a cardiologist at UCSD and until when they say uncle, they order a test? Or what's the best way to get your other cardiologist to order the test?
Yeah, and this is actually, I have research grants focusing on this topic, right? How do we improve the implementation of genetic testing for cardiomyopathy patients? Across the country, recent data from Anna Morales showed that 1% of patients with cardiomyopathy are getting genetically tested, right? And so there's a lot of implementation barriers here, and one of them is cardiologist resistance to doing genetic testing. A lot of it kind of comes down to comfort, right? We weren't trained to be geneticists, right? We don't know how to interpret, without appropriate training, we don't know how to interpret the results well. We don't have access to genetic counselors, right, as freely. And so there's a lot of different barriers, but I think working with the cardiologists and doing a lot of education is the way I've approached it, at least at my single center. But thinking about how do we do this, nationwide and worldwide will be key. And working with a couple of people to understand that, interviewing providers, interviewing patients to understand what are the processes and barriers that really are affecting the uptake of genetic testing. So I don't have a great answer for you right now. It's multifaceted, and hopefully in the next couple of months to years, I'll have more information about this as I'm doing more of this research.
Great, great. Thank you. We're going to go for 3 more minutes. If I don't get your question, I apologize. We'll get you the answer after the webinar. So from Amy, I have ARVC-ACM with 2 gene mutations. Do you foresee the ability to treat more than 1 mutation simultaneously? If treatment for 1 gene becomes available, will that benefit the second mutation?
Yeah, that's a great question. There are gene therapies looking to not treat the specific underlying genetic mutation, but maybe a little bit downstream. We think that there are certain genetic mutations in arrhythmogenic cardiomyopathy that basically converge and lead to the same pathway that leads to this arrhythmogenic cardiomyopathy. So can we target that convergence pathway and take care of all the different types of genetic mutations or variants that cause arrhythmogenic cardiomyopathy? And one person from our group, Farah Sheikh, is working on those types of things. So there is potentially in the future an option for that. But again, we're still in the early preclinical phases.
Okay, great. Last question. For those, I apologize that we didn't get to it. We'll get to your answers to your questions later. From Stefan Bassant from Lemonade Cardiac, great organization, great partner. He has this question. He's staying up late, I believe, in Norway right now. So thanks, Stefan. Do you see a time in the not too distant future where gene therapy can be delivered to muscle, both cardiac and skeletal muscle, at the same time in a patient with muscular dystrophy and DCM? And I got my 4-year checkup today at Ohio State University post-transplant, and I was talking to a patient that has both cardiomyopathy and a form of muscular dystrophy. So what do you think, Dr. Bui?
No, I think so. And I think that is hopefully in the near future. I think that some of these different delivery vehicles are becoming very sophisticated and exciting, like some of these antibody conjugates that compare with some of these genetic therapies can deliver to cardiac cells and skeletal muscle cells too as well. And so there is a hope and a future that we can target both the cardiac and the skeletal muscle effectively. So time will tell.
Great.
Exciting.
Great. Thank you. We're going to have Nikki now wrap up. Dr. Bui, thank you. I think that was wonderful. Great. For all of you attending this evening, thank you very much from everyone at DCM Foundation and Genetic Cardiomyopathy Awareness Consortium. Thank you so much. Have a great evening. And Nikki, please close out the webinar.
All right. Thank you to all of our GCAC sponsors whose logos you see on the screen now. Thank you to all of the patient partner groups for helping to spread the word about tonight's webinar and for their support all year long. Next slide. As stated earlier, you will receive an email with a recording of tonight's webinar. That email will also include a link to sign up for free genetic testing for adults diagnosed with idiopathic or non-ischemic cardiomyopathy. Next slide. We are excited to share that our next webinar will take place on Wednesday, August 20th at 6 p.m. Eastern Time. We will hear from 11-year NBA player and heart transplant recipient Scott Pollard. The registration information is available on the GCAC website, so please register online at geneticcardiomyopathy.org. If you cannot attend live, just register, and again, you'll receive a copy of the recording via email. And one last slide. Thank you, Dr. Bui. We appreciate your time and value your impartial expertise on the evolving topic of gene therapy. Thank you, Justine, for your behind-the-scenes Zoom assistance, and thank you all for tuning in. Be well. We'll see you in August.